Yeah, Dr. Pranay, can you upload your slides? Yeah, we will start the session. Dr. Baishak and Dr. Soumya, they are today's moderator, and I welcome them. And Dr. Pranay is presenting today's case. So, Dr. Baishak and Soumya, you can go ahead, introduce yourself, and followed by Dr. Pranay. Then we can start. Go ahead, please. Thank you.
Hello. Yeah, I'm Dr. Baishak Renuji. I'm from Kochi. I'm a consultant neurologist working in MOSC Medical College, Kochi. Uh, yeah.
Yeah, good evening, everyone. Myself, Dr. Soumya Swinkar, and I'm currently working as an SGPGI illness, and I welcome you all for today's session.
Yeah, Dr. Pranay, you can introduce yourself, then start case presentation.
Good evening, respected ma'am and sir. My name is Dr. Pranay Gupta, and I am a exam going resident in GP Pant Hospital, Delhi. I am presenting this case for presentation. May I start?
Yeah, go ahead.
Okay. So this is a 14-year-old. The patient is 14-year-old female, resident of Jewar, Uttar Pradesh, without any addictions known or any comorbidities. Was studying in 5th standard, and the informant was her father. She presented with chief complaints of progressive decline in scholastic performance, along with behavior issues for the past 4 months, and abnormal jerky movements of body leading to falls for past 4 months. The history of presenting illness, that with a normal birth and developmental history, she was at her baseline doing well in her school 4 months back when her teachers started complaining to her parents about her marks being reduced in the tests. She then started having difficulties in writing, started having difficulty in completing her homework, and started having difficulty in writing what was being told in the classroom. She then also started having episodes where she would not be able to recollect what was told to her both at the school or at the house. Gradually, over the next month, her father says that she started talking less and would and started to speak only when spoken to or coaxed to, but was still able to understand what was being told to her, and when speaking would speak normally. Over time, she started to talk in lesser words, in a few words, and for the past 1 month, she has been talking in 1 to 2 word sentences. But while she is still able to convey the meaning of what she wants to say, like she would be able to ask for food and or would be able to tell to her parents if anything is wrong with her, if she feels like vomiting or if she wants to go to the washroom. She would not show any disinhibited behavior, and no complaints of any decreased vision are given by. She does not have, she has other behavioral changes in the form of irritability and would get angry at her family if they would not do things according to her, which has been a change after the onset of disease as per her father. For the past 4 months, she is having abnormal, jerky body
We'll,
movements.
we'll start discussing the first symptoms. Let's go to the
Yes,
first slide. Yeah.
yes,
Okay. After the
yes,
chief yeah,
yes.
normal development, yeah. Okay, what do you feel? What all things are happening right now?
Sir, her the complaint started that she was having decreased scholastic performance, that
Okay,
she was not able to do as well in her school as she was able to do previously,
okay,
and then she started having difficulty in writing.
okay. So whether the scholastic performance was like anything specific, whether you were able to get from the history, whether it was like what all things can at this age? She's how old? 14 years.
14 years, sir.
Okay. So only scholastic in the beginning.
Yes,
So
sir.
at a 14 year or 12 or 20, 10 to 14 years, what all things you will think, when the patient is having a poor scholastic, and what all things you want to ask because it is pure scholastic.
Sir, first of all, if it's a non-cognitive issue which is affecting her, if she is having visual issues because of a refractive error, which is causing her to perform poorly, or if there are any other issues with her which are
Yeah,
leading to a poor
the thing
performance.
is when child is for 10 or 14 years, they will be able to tell that they are unable to see, their difficulty in vision. It's not like somebody, it's a kid who is going to first standard or KGs. This is somebody who is around 14 years, so she can tell. There's a visual
Yes.
issue, usually she will tell. So at this age, it is less likely. What else you want to think? Whether she was having lack of attention, what happens in the class?
Sir, what the father told us was a retrospective thing, that when I
Okay.
asked him ki, what was the first issue that you started facing, so then he told ki in the initially the teachers had told him that she was not performing, matlab she is not performing in that test that well as she
Yeah.
was doing earlier, but at
Yeah.
that point of time they did not put any heat to it
Yeah,
about any specific.
this patient, especially when it is like that means that this is not an acute onset thing, because the something which is happening slowly. That is why that even the teachers are not able to tell a particular point. Suppose in another patient, this is the same scenario you're facing. What you want to ask, what happened? I mean, if you want to inquire about things happening in the school, if you want to ask your teacher, what all things you want to ask?
Uh, so, uh, other writing, is there any grammar?
Writing
matlab,
issues, they will not have problem in doing oral vivas. They will
yes, sir.
perform well. They have only issue with writing. Poor scholastic means a gross abnormality. So most common is first is attention. This is most common is absence. You have to ask whether this is getting any absence issues.
Okay.
Sometimes in between the class they will get absence issues, especially 10 to 13 or that age group. After 7 years,
Yes,
a
sir.
childhood absence and all those things happens. That is a common thing. So whether during the class, whether the patient might not be knowing what happens during the class, only the teachers will notice that. Okay, in
Yes, sir.
between period, she will be completely fine also. So whether something like that, whether she is getting recurrent nodding of the head or eye blink, staring looks during the class, whether some complex partial seizure, something is happening in between, those things we don't know. Then
Okay.
anything else can happen during the class in this age.
Hence, then, sir, a differential of absence is, sir, like if a patient is having narcolepsy, then
Yeah, correct.
that can be.
Yeah, narcolepsy sometimes they will tell that like she will get a dose of in the classroom. In between, she will sleep off, or she may have sleep attacks or falls. And what will trigger this uh, cataplexy?
Sir,
Positive emotions or
a
negative
happy
emotions?
mood, a happy mood.
Yeah, positive emotions usually trigger
Yes, sir.
cataplexies. So
Yes, sir.
that also can occur, and that is very rare actually. Even though you tell all those rare things, but more common thing is an absence at this age.
Yes,
Then
sir.
it may not be neurological also. Sometimes, especially a female child, it may be something which like some psychosocial issues. Something happened at home, some psychosocial issues. These also affect the scholastic performance.
Yes, sir.
Yeah, yeah, so you have to consider the possibility of non-neurological also, especially when there is scholastic, because that is more common, especially in adolescent guys or girls, when they have only isolated poor scholastic performance, and otherwise they are normal at the home.
Yes, sir.
Otherwise, their behavior, everything is normal. You should think of other psychological, that whether there was something else, you have to do a counseling. Uh, you have to keep all the possibilities because those are more common than neurological things at this age.
Yes, sir.
Seizure is common. Then seizure, but they will usually find out, like at least at the home also, if the mother or father may see some of the absence, some of the jerks, they will find out, or at least the teachers will notice. It will not miss usually. Okay, then it can
Yes,
be
sir.
attention, lack of
Yes, sir.
attention,
Yes, sir.
or lack of interest. If it is pure scholastic only, and when you are taking a scholastic, actually, uh, especially for almost 10 or 14 years, whether that is affecting her cognitive decline is affecting her activities at the home. Sometimes they will be going to some shops and purchasing things, and she will be interacting with other kids. And how is she in his games or plays all around, not just studies. If it is pure cognitive, that also will be affected.
Yes, sir.
Yeah. So, like, not for this case, it will be very difficult to take the history, especially when it is a slowly progressive illness, and especially in our patients, if they are financially backward community, they may not be notice all those things, but otherwise you may get all those things also.
Yes, sir.
Okay. Then she is having difficulty in writing. Okay. Okay. What was difficulty? What when difficulty in writing? What all things will come to your mind?
So difficulty in writing, there can be various components, sir. If she has
Yeah.
difficulty in writing to a verbal command or copying from the or writing with memory, if she is giving a test, so various components we can ask.
No, no, when somebody tell you history that she has difficulty in writing. So what all things should be asked at this stage, particularly?
Also dyslexia and so whether the grammar is correct what she is writing, and
Hello, am I audible?
yes, sir, yes, sir.
Yeah. So the writing can be whether she is having difficulty in holding the pen, or whether she has dystonias or involuntary movements happening while writing, or whether she doesn't know how to draw, or she find it having apraxias, or it is weakness, or it is a gross language dysfunction, or how is the calculation part affected, especially when they're school going, whether it is specific to calculations. So these all things as values, especially somebody who has poor scholastic performance at 10 or 14 years and having difficulty in writing alone. If you are telling that he has difficulty in writing alone, you will think of more likely to be a dystonia also. That is more common at this age.
Yes, sir.
Dystonia or some involuntary movements. Writer's cramp, all those things are very common at this age.
Yes, sir.
So if such a scenario is there, what do you think of? The one disease you want to rule out in India?
So, an extra problem in a young
Fourteen-year-old
adolescence.
child having some cognitive decline and difficulty in writing, and you're thinking of movement disorder. What do you want to
So
rule out?
Wilson's is the first
Yeah,
thing we should
Wilson's.
rule out.
Yeah, Wilson's you have to rule out.
Yes,
So because you have to keep everything open, because when you have the myoclonus thing, those you will think of other things. But if you analyze each symptoms, another patient will be different scenario.
yes, sir.
So if it is writing, it can be either motor or involuntary movements or movement disorder, or it can be because of a cognitive dysfunction. And whether it is only writing is affected or other things are affected, other movements of the hand, how is doing other activities of the hand, especially writing is the right hand, then you have to ask activity of the right hand, whether it is anything is in the other hand, or all activities are affected.
Yes,
Okay, ma'am, anything to add, ma'am?
Yeah. Actually, when you are describing this history of difficulty in writing, at that time you should differentiate exactly the sir was saying. The first, whether it's a higher problem or it's a lower motor neuron issue. Okay. So if it's a higher disorder, you have to see whether there's a problem in the cognitive function in the form of language dysfunction, or whether it was a form of a higher order dysfunction in the form of apraxia. Then, whether he is having any association in terms of extrapyramidal disorder like dystonias or any poriform movement or athetotic movement, or some task-specific dystonias, or whether it's other thing. And then you have to see whether it's a lower motor neuron weakness. The patient is unable to hold the pen, or whether it's a sensory issue. Okay, so that thing has to be very clear when you are saying there's a difficulty in writing. And along with the difficulty in completing her homework, what does this mean?
Ma'am, what he said was that she would not, matlab, they would, the parents did not keep a close watch on her, but there would be complaints from her school that she was not completing the homework which was given to her.
I mean,
So,
why the what not completing? Whether doing wrong home, wrong that answers she's writing in her homework, whether she is not doing her homework at all, or was there any mistakes that she was making? So that detailed history we need over this part. Okay.
Yeah. Also, how, whether she was able to read aloud, whether she was write only or reading alone, whether it is language or it is motor, and if homework also, whether it is what is the problem, like madam was telling, like whether it is copying, whether it is writing notes, whether it is doing calculation, only with max homework she has problem, or making it mistake, or she was not attempting, or she was forgetting it. All those things has to be there.
yes,
So the writing also, there was a spontaneous writing was abnormal, whether she was unable to copying, whether it's for dictation that was giving that she was not making. And in writing, what was happening? Was she making the incorrect words? Was she was missing some the connecting words or the pronouns among them, or was she missing nouns among them? So that is all important, okay?
yes,
I mean, not in this case, but in case of PP, if you're encountering a patient of PP, you will find these abnormality. They do have a difficulty. They are having agrammatism. They leave the grammar in between. If you ask them to write something, they will just write I go. Or they will just leave everything, all the grammars in between. That is important.
yes, ma'am.
Come to the next point.
She started
Where
at
she
the,
was,
yes, ma'am.
yeah.
She also started having episodes where she would not be able to recollect what was told to her in the school or at the house.
Okay, so what does that
What does
means?
this? Hmm.
Well, sir, in this scenario, it would probably mean attention deficit, which has started to develop.
Okay. And even this, actually, you have to elicit some scenarios if possible to get like any events they remember, whether there was some gross mismatch, there will be something else. I mean, you need much more detailed history. Like this is just like presenting complaints. You have to get a more detailed history. What is happening? What all things was the mystery collecting? Whether she missed any items, misplaced anything, lost anything, or whether she remembered after coming back whether she had missed lost it. But this won't be like all on a sudden on one day. This will be slowly progressing. So there will be much more details actually required for each episode. What is happening for that?
Yes, sir.
Yeah.
In this, whether it's an inattention or it's an episodic memory impairment that we want to differentiate, okay? So
Yes,
in that case, you need a detailed history regarding that. It's an episodic memory, whether it's a visual memory that is more involved, or it's a verbal memory that she's more forgetting about. She has misplaced her things. So, or whether she has just forgotten the conversation or things which were asked to do her, and then she forgot, and then she's again doing the same thing. Like the history you take in dementia patient. So
yes,
cognition is cognition. If you are saying that she is having episodes of forgetfulness, so was it actually inattention or it a memory impairment? Both are different things.
yes.
So the detailed
Yeah.
history is needed in that.
Yeah. Again, the history, the entire history is from the school only. So she has only problem at the school, or she has problem at the home also.
Sir, the issue was that the father was accompanying the girl,
Okay.
and what he told was what was told to him when he would come back to the house, that these are the issues that are coming up. But after, when she started having other issues, and when she started falling, and when the cognition was on a global level, that is when they started to really bear down on
Usually,
her. Yes, sir.
if suppose this everything is like this, like what you're telling, this everything is happening at the school, then it is non-neurological, especially in a child, adolescent child. You have to think of something happening at the school, which needs to assess and get a psychosocial support, because if it is cognitive, it has to be there throughout the day. It's not just the school. So when you're writing such history, you have to ask and try to find out some detailed history. Just telling some episodic memory loss is actually not what is required. What is required is at least try to get one story or two stories of one event or two or three events what happened during the process. Suppose she forgot some notebook or something like that, or she had misplaced something and they went to somewhere and she got lost in that place or something like that. Some history you are able to elicit in detail, that will be much more beautiful to elaborate the history, because this can be anything like when you tell misplacing thing can be even normal part, even anxious patient, depressed patient, inattentive patient, or patient is not interested, or if it's actually a cognitive dysfunction, all these things can present. All these three history, 3 points which you are told is everything is happening in school. So this can be psychological also, functional also, because this is, nothing is happening at the home.
Yes.
Yeah.
See, when an adolescent female child, and along with this kind of history, later on developing your myoclonic jerks, and along with that some other cognitive decline, the initial history could be a part of some psychosexual abuse also.
Yeah.
So that's why it's important, because in that case, your HIV or your sexually transmitted diseases are very much important differential in subacute onset, sudden onset seizures with cognitive decline with prior history of these kind of things. So that's why you need to be differentiated very carefully. Okay.
Yes, ma'am.
What is the next history?
Then, sir, with gradually over the next month, the father says that she started talking less and would speak when she was spoken to, when they would ask her. And but when she would speak initially, she was speaking in a normal language. But over time, the sentences shrink in words and was speaking in started speaking in only 1 to 2 words. That she would only say कि खाना है या फिर उल्टी आई,
So
only in 1 or 2
during
words.
during that time, how was her other activities? Whether she was doing all activities, or whether she was apathetic, or whether it is a language or speech.
So the predominant was that apathetic part, that matlab she was remaining to herself. She was not talking to anyone, and matlab she had to be coaxed to be talked multiple times. That what do you want? And only if she had any problem, then she would say, and then too only in a very less amount of words she was talking.
If it is apathy, it
Only
is
in
not
terms,
just talking. It will be
yeah.
affecting all other spheres. She will be apathetic to other activities. She'll be sitting there. She was not doing anything. And it can be even depressive also. Patient also can behave like that. So you have to be very specific. Just you're telling only about the language or speech aspect. What about the other aspect? Whether she was playful, whether she was involving with other activities, how was she with the friends? All those things also matters. Whether apathy will affect all the spheres, not just for speaking. If it is isolated speaking only, then it can be either a language or speech disorder sort of,
Yes, sir.
because
Yeah,
we already had
exactly.
discussed
And
in writing.
whether, yeah, so whether it's just a language problem or whether it's a part of apathy, or was it is a language problem or was just it's a mood disorder. So at the same time, you have to tell what was her mood itself, what she used to say, how was she interacting with other people like her friends, whether she was playing with them or not. How was her sleep at that time? Whether she what was her appetite at that time? Was she tearful most of the time? So how did her face look like? Was she sad from her face? Although the patient currently is not in that state, but whether her affect is low at that time or not. So that history you have to ask. And then whether it's a mood disorder, whether it's an apathy, it's a language disorder, or whether it's a speech disorder. Both things are different. Okay.
Yes, ma'am.
And in language disorder, you are seeing it's just 1 to 2 word sentences. So what sentences? Whether she was using only noun, whether she was using noun along with pronouns she was using. Was she using some grammar or not in between them? Was she missing grammar when she was speaking? So that is important.
How to differentiate empathy from a depression or something like a mood disorder?
Sir, in a depression, the patient themselves will complain of their symptoms, while in a patient of apathy, the relative will complain that the patient is having these issues.
Anything else? They may or may
Then
not want it.
yes, tension in depression, there will be associated multiple sensory features, sensory complaints that the patient might have. Other non sensory complaints, while in apathy, it might not be the case.
No, what is the core difference between apathy and depression? See, apathy is something which happens in the motor, but the thought process is not affected. The thought process is affected in the case of depression. Depression is a disorder of thought where their thought process is negative. They will have hopelessness, feeling of doom or want to die. They feel depressed. Their expressions and thought matches. While in apathy, their thought process may be normal. They don't have that effect. They don't have the emotions of depression. And second, uh, and they will, like madam was saying, they will be showing excessive crying, or they will, the mood and effect will match together. They always have the negative feelings that will not be there in apathy, because apathy is not a disorder of thought.
Yes.
Okay, so when you're telling
And
the speaking less, you have to
see,
be very clear,
yeah, yeah. And one more thing. I mean, if you ask the patient of a mood disorder or the depression versus apathy, the apathic person won't say I'm tearful or I'm sad. Only you will see the person that he is not interested in your things. Okay, versus a patient of depression, they will have an effect of sadness along with that. If you ask them how do they feel, they say, okay, I don't feel well.
because
Yes, sir.
you are not dealing with an adult here, you're dealing with a child around 14 years. So the disease spectrum will be different. So if she has so much problems at school and she's not talking only, otherwise normal, you have to ask about any depressive symptoms, psychosocial, functional. Those things are more common. Like madam was telling, some assault or something, some other issues might be there. They won't open up that easily. So you have to keep non-neurological things first in such cases, and you have to make sure the history has to be much more detailed. Like you have to get the details what happens in between during the other activities, how he's at school, how she's to others, how she's doing her playtime, how she is with her colleagues, with the friends. All those things has to be there, and then you can details of speak language, differentiate whether it is a language, whether it is a speech, whether it is a cognitive disorder which is causing this. Okay.
Associated there were behavioral changes in the form of irritability, and she would often get, matlab, has started to get angry at her parents if they would not do things according to her, which was not the case previously. But associated any disinhibited behavior she was not showing, and there was most of any decreased vision which was given.
Okay.
Then so the second chief complaint.
Wait, go back. What are the domains of cognition in which you take history of dementia?
There are 6 domains of cognition: uh, executive function,
Yeah,
attention, uh, language,
yeah,
memory, a social cognition, and a perceptual mode.
yeah. So whenever actually you are describing the history of cognitive decline in some patient, you have to at the same time you have to tell regarding these domains as well. For example, a patient you said he was having probably a language domain involvement. Okay, might be some memory part. We are not very clear whether it's an attention part or it's a memory part. But other domains you have to tell whether there was any executive dysfunction or not. Because if you are saying that your patient is inattentive or your patient is apathic, so at the same time your other aspect of the frontal lobe or the other aspect of cognitive domains are important. Especially you should tell regarding this execution. Okay. You told regarding auditory frontal lobe regarding disinhibited behavior. At the same
Actually,
time, you have to tell regarding this execution also. Other than that, you have to tell regarding how was her social behavior. So that also has to tell what was her perceptual motor. Was she having any hallucination, visual hallucinations or delusions? Was there any fluctuation in symptoms over days or over diurnal variations were there or not? Okay. Then, regarding
Okay.
some navigational difficulty, was she encountering? Could she recognize all her family members or not, also distant relatives? Was she interested in some playing or some games she or some sports she used to engage previously? Is she able to do that? Or what difficulty she was having in that, or was she not having any interest in doing that? So all part of cognition will come at one time.
Yes.
Okay. And if you are at the same time, if you are telling regarding the cognitive complaints, vision won't come over here. Either you keep it with the cranial nerve part. I mean,
Okay.
why specifically we are just telling regarding, although if you are saying that she is having difficulty in writing, then at the time you can tell that she patient is able to copy from the blackboard. She could see, but still she is unable to write. So at that time it is fine. But defining vision in the middle of cognition, it's before your second complaint, I don't think it's justifiable over here.
Okay.
Sir, anything else? Sir?
Around. Yeah. Yeah, I think whether she has any other cognitive function later, you are coming to another cognitive issues at the end. Anything else
Sir,
happen chronologically?
sir, her connection in the speech and the behavioral changes. She answered because she started having these points, which was the
I know.
second
I was
complaint.
asking is like you want to go in a chronology. Suppose that you can use it either ways. Suppose these were the first symptoms. What she was having is with apathy and those things. Then she had myoclonus. Then later, after later, she has some other cognitive dysfunction. If you want to go in the chronological order, you can keep all negative things together at the end. If
Yes.
you want to go in the chronological order. But if you are start telling the negative part in the midline, like midway of the history telling, like you want to finish the cognition there, then you put all negative things there. Then you tell other part of
Otherwise,
cognition also there, if nothing is there. Either you put in middle or you put in the end. Otherwise,
yes.
it will be mixed up. If
Okay,
you
sir.
want in a chronological order, you can tell attention, language, or empathy was there. Then she had developed myoclonus. Then later she developed a hallucination. Then you can go in that order, no problem. But if you are introducing some negative history in the middle, then you have to finish it there. And now this one is only cognition affected, no other cognitive symptoms were there. Then she developed myoclonus. Then she had something else. Then it is more reasonable. Either follow either of the way. Don't mix it together. Otherwise, this question will be there in the exam also. Like why you're not completing or whether other cognitive system, what happened to that? That will naturally come. Okay.
Uh, then on the second complaint, for the past 4 months, she is having a sudden abnormal walking movements, which would lead to falls. And earlier, these movements would occur infrequently, which gradually with a gradually increasing frequency, such that they now occur every few minutes or sometimes in every minute. During these episodes, her jaw opens and her head goes backwards, with her falling to the ground if she is not supported by anyone. If the episode happens while she is standing, these episodes are absent in sleep, and because of the frequency of these falls, she cannot go anywhere unaccompanied, even to the washroom at present. And these episodes are not associated with any history of any generalized seizures, any other abnormal hypo or hyperkinetic movements. Then negative hysteria.
Just go back.
Yes.
Yeah. So this movement you have explained the body movements. In which part of the body? Limb, trunk, hand.
But it's a generalized person. There is no specific operating addiction to any arm or any legs.
It was present only in the standing.
Sir, it is matlab, the maximum seen when she stands because she falls of because of these episodes. But when she is lying down, only her head will slightly go backwards and her jaw will open.
So what happens when she is trying to take something or take the food? How what happens when you eat or write, or whether she combs, or whether she do some other activities, wearing dress or something, whether this comes or goes, or become static or will not be there.
Yeah. If she is there. activity like she was eating. When I
So
saw it,
that,
and in this
so
episode occurs,
yeah, this
fall
has to
out
be
of
there
her
in the
hand.
history because you have to, when you are telling a movement disorder, you have to be specific, if at all, from the history, if able to get, you have to specific which part of the body is affected, what happens with movement, what happens in rest, what happens in different postures. Because from the history, what I made sure is it is something happened in the trunk and the head, nothing happened in the limbs. Because the movements are in the limb, then there will be some difficulty in mixing food or taking the food to the mouth, or in between doing some actions. She might have some problems taking a glass of water, at least a spoon from, I mean, some curry from the spoon. There'll be some difficulties will be happening. You can explain that because when you take the history, it should, especially movement disorder, if possible, it should be like when you end up the history, it should be like the you as well as examiner is watching the moment, if possible. If the patients are telling it, at least part of something you just visualize in front of you, you can explain it that so that the examiner as well as you will feel like you're watching it. If that much details are able to get, that is good and fine, but that should be from the patient's word, that should not be from your examination. If you have to ask these things, what happens during action, what happens during each movement, how she is doing, if this much disturbance is there, how she is taking the bath, whether it is affecting her ADLs, what all things she can do right now, because as per the history this is very much affecting her daily activities. It should be, because standing it is very much increasing. And how is the progression? In the beginning it was this much or started in some area, then slowly progressed, and now what all areas are involved, whether there is a loss of conscious during the fall. Anything to add, ma'am?
Yeah, one more thing. You have to tell regarding diurnal variations, whether it's more in the morning or it's more in the evening. I mean, it's what time it is more. For example, you see classical inpatients of JNU, they are having early morning myoclonus or the morning myoclonus. Other
Yes,
than that, in myoclonus, very important is stimulus sensitivity. You had to ask whether it precipitates its own or whether it is whether the patient has some loud noise, does it worsen? If you touch them, does it worsen to that? Okay. The tactile sensitivity, the auditory sensitivity, or the internal emotional response, does it worsen to that? So it is important in that case. And importantly, whether it's associated with loss of consciousness or not. Because of that, did your patient encounter some kind of traumas or injuries due to these movement or due to these falls? Okay, and if they're encountering injuries, that is also important. Whether they're having injury over the knees or their chin, or whether they are having just injury towards their backside or the back of the head. So that will also help you and that will also give you clue whether you are dealing with atonic seizures or you are dealing with PSP like falls or you are having myoclonic jerk like fall. So the part of injury is also different. Okay.
yes,
Were these episodes completely absent in sleep or reduced in sleep?
ma'am. As per the relatives, these episodes will not occur in sleep.
Yeah. And it was only in the truncal movement. Was there not any limb movement she was having?
In the
Was
movement was
she
not in her, but yes, so whenever she would hold something, episode will occur, then she was
your
having
voice is
something
not
in that episode occurs.
your voice is not clear, Dr. Bala. Yeah,
Hello, ma'am.
was she
Hello,
in?
ma'am.
Yeah, hi. Yeah, hi, hi. Yeah, now it's clear. I'm asking, was she having only limb or truncal movement, or was there any associated limb movement as well? Because she's having head movement, it is jaw involvement, it's a negative jaw myoclonus that she's having. So limb
Yes, ma'am.
movement also, limb jerkiness was not there.
Ma'am, any prominent jerkiness was not there, but whenever she would hold something, like if she was holding a food or a comb in her hand, and then an episode would come, then it would fall out of her hand. But no
See, it is
jerk per se
important.
was,
Yeah,
yes, or
see,
they were not
the
mentioning any
myoclonus
that.
can, yeah, myoclonus can be positive or negative both.
Yes, ma'am.
Okay, so that is also important. You have to just tell in that history because The patient is falling on the jaw opening myoclonus. So whether it is a negative myoclonus or positive myoclonus.
Ma'am, negative macrons.
Yeah. So similarly, if she's encountering some sudden fall on from her hand or some things are spilling or food is spilling, you might be having limb negative myoclonus as well.
Yes.
So that has to be told in which part of her body she was happening, whether initially it was generalized to onset or whether it's some body part that she was to onset and then it became generalized.
Ma'am, from onset it was generalized. No any focal
And
initial any focal event was not there.
no multifocal or erratic myoclonus were not there.
And also you have to mention whether like the part of the body involvement is very important. You have to tell which all areas, how it started, how it progressed, and what happens, aggravating, relieving factors like in action, what happens, in movements, what happens, at rest, what happens, in sleep, what happens, diurnal, what happens, and how it has progressed, and how it is affecting her ADL. All everything has to be there.
Yes.
Okay, go ahead.
Then the other history that the father gave that she would come that the father would complain of stiffness in her legs when he would help her during the day. And in the negative history, there was no history of any diplopia, any abnormal facial sensations, any dribbling of
The
saliva or
stiffness
liquid.
also, detailed history has to be there. What happens with upper limb, or how it is stiff, or how can make out it is stiffness, whether he is dragging, whether she is getting up difficulty, whether he is wearing dress difficulty in bending knee, or how she wears the slippers, whether there's some difficulty in wearing slippers, how she is able to mix food, whether she is able to button unbutton. Limbs means upper limb or lower limb.
Sir, okay. What he said, sir, the verbatim, what he said was that he was finding it more difficult to manipulate her limbs when he would help her during the day.
She is not giving any history, right?
Yes, sir, she is not giving any history.
Okay. Then you can ask what happens in the beginning, whether she walks. You can even sometimes you can even imitate them. The walking, if they're poor history tellers, you can imitate in front of them whether she walks like this, like that. I used to do that because I did in Karnataka where initially I don't have not that much Kannada, so I used to act in front of them. How she was walking, how she was upper limb, and how she was wearing slippers. Whether she was any difficulty in wearing slippers or they stop using slippers. How was the gait progressed? And how now she is walking
Sir, no, sir, she is bedbound.
bedbound. So how was the progression? How was the stiffness worsened and she became bedbound? Whether it was only because of stiffness or whether it was because of involuntary movements.
Sir, the bedbound nature of hers is because of her falls when she's walk. She's still able to walk with support of her father. If he'll take her hand, she'll be able to walk. But the issue is that within a minute only, she'll have a have an episode and fall to the ground. She has often has had injuries also because of that. So that is the reason why she's bedbound at present, not because of any weakness or any motor component
Okay,
predominantly.
you have to tell all those things in the history. It has to be there, like how was the progression, what happened, and why she became by this time she became bedbound, and why she became bedbound. Because when she tried to walk, these movements are coming, or whether because of stiffness. And stiffness in limb, how is upper limb? Whether they found any difficulty with upper limb, whether they found when she was getting up from the bed, there's a truncal stiffness was there, whether it is like any features as stiff clonus. Clonus sometimes you can get from the history. So that much details has to be there.
Yes.
And along with that, you said that yes, she has to hold the hand of her father while walking. Why is so? I mean, if she's fallen, they can just walk with them. I mean, she can initiate her own. Whether she could initiate her own or from the initiation only she needs help.
She is able to initiate, ma'am. She is able to walk on her own, but the
And that
issue is that
walk was normal. That walk is normal. There is no walking on toe walking or heel walking like
no,
that.
ma'am, no, ma'am,
Or any dystonic foot movement was not there. Nothing was
no,
there.
ma'am, no,
It's
ma'am,
just a fall, so that's why they have to. And that fall, even though you give some support, would she fall or it would just have some improvement in that fall?
no, ma'am. She would fall, and they would hold her to let her to avoid or letting her falling to the ground.
Okay. Why it is important? when you are taking history of fall on walking, why it is important that if you give some support, the patient fall changes or it is the same.
But it can be because of a cerebellar issue. If it's because of a
Yeah, if
cerebellar
it's an ataxia or the cerebellar
ataxia.
ataxia versus
Yes,
the atonic seizure. So that's
yes,
why it's important. The atonic seizure, you give them any support, you give them walker or anything, they would fall because it's a negative tone.
yes,
Okay. Versus the ataxia patient or the patient of MSA, QMC, no, they are falling through because there is now they are having some support to walk. So this history should also be given when you are giving a history of gait abnormality. And when you are giving a history of stiffness in our limb, so as sir said, you should tell what part, what limbs were involved, whether it's just a lower limb or upper limb, and whether if you need to differentiate from the pyramidal weakness or the pyramidal stiffness or UMN, what are the important things that would indicate it's a upper motor neuron pyramidal system involvement?
and more involvement of the anti-gravity muscles would be in
Yeah, so we would ask that when she walks, whether she goes for a toe walking or whether she keeps her foot normal. Along with that, you will ask for clonus. You will ask for mass reflex. You will ask for flexor spasms.
yes,
Okay, so these three things are there that which helps to differentiate whether it's a pyramidal stiffness she is encountering in her limb or it's an extra pyramidal system she is encountering. That can give a clue. Okay, and
yes,
along the same time, if you want to say it's an extra pyramidal, but same time you can add that although there was no tremors or there was no tremulousness on walking, so that will give you a hint that it's not an extra pyramidal. So in that way you can direct your history.
yes,
Okay.
Yeah, actually, the history has to be detailed, and the examiner should know that from your history, whether it is stiffness, whether it is rigidity, whether it is ataxia, or whatever it is causing a difficulty to walk, whether it is the myoclonus is causing, that has to be evident from the history. The history should tell that. Without asking any question, history should tell that this is happening to the patient. That details has to be there. You cannot just give that complaints of stiffness. That is just a present complaint, presenting complaint. That is not history of presenting complaint.
yes,
And now here when you give a history of diplopia, before that it will come now that whether a patient is having any visual impairment, then it will come to diplopia and then the facial sensation. So if you're giving all cranial now, it will come as a one part cranial now.
yes. Then
So
other
the
negative is
patient
that
is bed bound, but she is able to tell regarding her bowel and bladder functions.
and there is no, matlab yes, ma'am, she is able to tell, although in a single word she will be telling, but she is able to inform her attendants that she wants to go to the washroom.
Oh, okay.
No stuff, no stuff any tremulousness while reaching for objects or swaying to any side while walking. No stuff any fever with rash in childhood. No stuff any chronic
So
diarrhea.
wait. Over here only. You do your symptom analysis of your localization first. Then you go
Yes, ma'am.
regarding the etiological history.
Yes, ma'am. I have done the symptom analysis, ma'am.
Okay,
Matlab
fine. You can
in
go ahead.
in the
Yeah, yeah, no
subsequent
issues.
slide.
Sure. Okay, okay.
Should I go to the symptom analysis first?
No, the detailed negative history will be needed. No? It's just 4 month history only. Just keep
Yes,
first negative history. The etiological negative history you were telling. So just tell them this.
that there was no history of any fever with rash in childhood and no history of any chronic diarrhea in the patient. And there was no history of any fluctuations which were present with fever.
What else negative history will ask in this section? Am I audible?
Mm. Yes, ma'am. Yes, ma'am.
Yeah. What are the negative history? It's just two things we have asked regarding fever with rash and chronic diarrhea.
Yes, ma'am. There is no any acute event. There is no history of any fever. There is no history of any fluctuations which are present. There is no history of any other delusions, hallucinations. There is no history of.
In
Then
your
no
history,
visual
you told regarding only two things, no? One is the
yes, ma'am.
cognitive decline, and another one is your myoclonic jerks.
Yes, ma'am.
And these are so severe that a patient within 4 months is bedbound.
Yes, ma'am.
And it's just a 4 month history that they noticed, right?
Yes, ma'am.
So what
Yes, ma'am.
differentiate between them? What are the things that can cause this?
When the
If a
differentials, I'll
female, adolescent female, I mean, I'm just asking this question because I think regarding etiology, then only you will take the negative history in your etiology.
yes, ma'am.
That is
Once
my
it's
point.
ma'am, a subacute history of
Yes,
cognitive deficits with a
yes,
myoclonic
there is
jerk.
some. Yes. So what we can think of? What
Uh,
diseases it can be?
Ma'am, she also has a history of an incomplete vaccination history. So the first differential that would come would be a subacute sclerosing panencephalitis.
Definitely SSP is a history, but SSP is not a treatable condition.
Yes, ma'am.
So we
Then,
always try to give advantage to the treatable conditions first.
yes, ma'am. Then, ma'am,
Definitely we go with the EEG, and if we are getting a classical EEG, then we are just sure. But in history aspect, you have to see whether so you'll ask for some autoimmune history if your patient is having. If your patient is having history of thyroid dysfunction, they can also have cognitive decline, myoclonic jerks, and then the patient is bedbound. Okay, then your metabolic diseases, your parathyroid abnormalities, these patients can develop this kind of presentation.
okay.
And
Then, ma'am, the other differentials would be other progressive myoclonic epilepsies, which
yeah, other
can,
progressive, then infection, HIV.
yes, ma'am.
Your HIV is there, your syphilis is there, the tertiary syphilis, they can present. So then you have different malignancies like hematological malignancies. If your patient is having multifocal problem, your patient is not having one single problem. It's a multifocal issues. So then in that scenario, you have to ask regarding history of weight loss, chronic fever, any class B symptoms the patient is having or not. So all that negative history you have to tell.
Yes, ma'am.
Okay.
Okay.
And then you will take the history for the degenerative diseases, like the other progressive myoclonic epilepsies, you will take the history. Anything to add, sir?
Actually, for me, there are some range issues, not audible, most of the things. Yeah,
Oh, actually I was saying regarding sir that negative history has to be elaborate in these cases. So just a 4 months subacute history, we just
yeah,
cannot directly jump over SSP.
yeah, correct. Especially when it is 4 months, you have to keep the treatable things first.
Yes, sir.
Especially like Madam was saying, some infections, autoimmune. Then sometimes even because they basically take the syndrome, it is a cognitive plus movement disorder plus some stiffness. It can be either pyramidal or basal ganglia. So it is a multi-system. So you have to think of something systemic also. Sometimes in this stage it may be lymphoma, intravascular lymphomas, or some malignancies. So you have to keep all the possibilities because SSP is also should be kept, all the degenerative things, and even some of the mineral associated mineral deposition disorders. Like because this extrapyramidal syndrome with cognition and probable pyramidal. So you can keep those things also like Wilson's, even though down the list because it is treatable, or
Yes.
even NBIA spectrum.
Yes, sir.
All those things have to be there. Uh, I think even sometimes if the history is 4 months, you can even keep. Sometimes it may be demyelinating disorders also. Rare, but it can be just 4 months history. No?
Yes.
So, go ahead, please.
Then the other aspects of her history, uh, her vaccination history was significant that it was incomplete, that she had only
Yeah, because
taken the dosages at birth.
yeah, 1 second. Somebody asked autoimmune encephalitis definitely has to be considered. 4 months history with extrapyramidal cognition should be there. That should be first DD. See, this happens because you already know the case and you have the final diagnosis and you're starting from there. So this happens in your exam also because in exams there may be cases which already you might have seen or your juniors will take the case for you. That happens in everywhere. So one day or one day prior, they will tell you the diagnosis it is SSP. You will be stick on that. So always, when you even if you have diagnosis, you present as if you are saying the patient want to evaluate in your ward or in OPD. Then you keep when you are seeing as a consultant and seeing that patient, you will be interested in treatable disease than this non-treatable disease. But when you are a student, you will be interested in making diagnosis of syndromes or diagnosis of degenerative things because those are more interesting as a student. But as a consultant, this is more important is whether it is treatable or not. So keep all the DDs before you get stuck onto the diagnosis given by your junior PG or the case you have seen. That is a problem which happens in exam also. Because many cases will this case will be kept for your exam. You know it SSP, you will put everything towards SSP. That happens in history also. You will be putting everything for the one, two, three things for the SSP because you are not thinking laterally because you are narrow minded because you have the diagnosis. So even if you have the diagnosis, think of all the possibilities. Keep it open.
Yes.
See, like we told in previous classes as well, it's like a past history. You told it as a no significant history. It should not be written like that. You have to write in detail, complete detail. There is no history of diabetes, hypertension, or other chronic medical illnesses like thyroid disorders or any surgical history. So the detail is detail. Okay, don't go in this directly like no significant history. Don't write it like that. Okay.
Yes.
And
Even the
regarding
vaccination
vaccination
history.
history, yeah, the vaccination history as well. If they can tell you whether it's there or not, then you just say the vaccination history was available or not available. If available, then you have to tell regarding complete. And at least you can make that the BCG mark was there. Okay, this much. Even if you don't have vaccination history, you have to tell this thing. The BCG mark was there or not, whether patient received vaccination at birth or not. I mean, bare minimum the family can remember that should be told in detail.
Yes. Ma'am, the patient took vaccination. Only the first doses at birth were given to her. The rest of the doses were not given to the
Yeah,
patient.
you have to mention that
Yes,
whether if you
yes,
know what
yes,
all vaccines, you have to mention that and like BCG mark, all those things you can mention. And
yes,
if you know the details, you can tell this vaccine is missed. That is difficult to get because especially those who are not vaccinated, they will not be knowing about what vaccine, what happened, and but you can mention till
yes,
what age at least he has taken vaccine.
yes.
You can even
After
And
mention
the
that
birth,
she has taken vaccine from the government hospital after the birth till this age, whatever vaccines available to the government. That will give you more cue that what all vaccines might have taken.
yes,
Yeah.
and in the birth history also, it should be complete. It's a whether it's a full term, whether it's a preterm or post term, then the normal vision and delivery, and then definitely good. It's an immediate cry. Birth weight was there. What do they know? And if they don't know, then we will just say the birth weight is not going to the family. Was there any perinatal complication or not? If no perinatal complication, then with no perinatal complication, any neonatal admission, any jaundice, at least two, three things, a jaundice or a history of HIE and a history of meconium stained liver. Two, three things that are common during these perinatal, the common perinatal problems that should be told when you are telling the birth history. Okay.
yes,
And again, the developmental history. This should be in detail because the patient has developed cognitive decline. So you have to tell, not just write directly normal for each. If they can remember, just tell every domain, the gross motor, fine motor, language part. That has to be told in detail. And if they don't remember, then you can just directly say that they do not remember these things. And they remember these things out of the milestones that we asked them.
yes,
Yeah, especially in this case, she is 14-year-old and the history is very short also. You have to keep you're keeping the possibility of a mitochondrial storage disorders, all those things also. So you have to take a little bit more details about development history also.
oops. Then in her personal history, that she has a mixed diet and her bowel bladder is regular, but her sleep and appetite both are decreased.
In
And
what manner?
she,
What
yes,
manner? Detailed sleep history is important. What happened to her sleep?
And the father told that matlab, there were multiple awakenings during the night. There was sleep
What was the,
fragmentation,
yeah, and what was the latency to go to sleep? What was
latency.
the
He did not.
frequency? Yeah. And whether there any early morning wakefulness was there or not in the initial part, and then how it did change over the course of her illness. Was there any reversal in wake sleep pattern or sleep wake pattern? She's sleeping in days, awakening at night. Those things are important. Detailed sleep history. Okay.
Yes,
And appetite. How much appetite reduced?
ma'am, ma'am, because
Mm.
she matlab, said that she was not uh, eating uh, matlab, when compared to before 6 months back, the appetite she had at that point of time.
What appetite? We used to tell in our medicine, no, this much chapati previously in our system. So that has to be objectively assessed. Please go ahead. Mm. Yeah, please go ahead.
Yes, ma'am. Then in our family history, ma'am, there was no similar history, similar illness in the family, and
What
no
is
family history.
important? What is important? What did you forget in asking family history? Consanguinity.
Yes,
It's important, no? We are dealing
yes,
with a
ma'am.
person with cognitive decline, extrapyramidal, some pyramidal aspect. There are so many PMEs, movement disorders, different MBIs, uh, way of transmission is whether it's a dominant or recessive. So the consanguinity is very important, and a
Yes,
family too
ma'am.
should be there.
Yes,
The first degree consanguinity or consanguinity among grandparents was there or not? What was the community that the patient belonged to?
ma'am. The patient belongs to the Muslim community.
Then again, it's very important.
Yes,
And in Agrawal community, some disease was specific to them. Can you just elaborate what are the diseases to Agrawal community that you know?
ma'am. There is spinocerebellar ataxia type 12.
Okay, and
Um, and two more diseases are there.
the leukodystrophy is there. And
Ma'am, yeah, ma'am, megalencephalic leukoencephalopathy.
megalencephalopathy. These megalencephalic leukoencephalopathies. Yeah, my voice is not clear. Is it clear, doctor?
Yes, ma'am. Yes,
Yeah, so megalencephalic leukoencephalopathy or vanishing white matter disease. These patients, although it's slightly different presentation, but they also have similar cognitive decline if they're presenting at later age. Although the age of onset is very early in those diseases, but the presentation is of cognitive decline, extrapyramidal, pyramidal dysfunction. So they also have these kind of things. Okay,
yes, ma'am.
so the family history should be in detail. Okay, go ahead, please.
Yes. Then, on the summary of the case, ma'am,
Addictions,
that yes, ma'am.
addiction history.
Ma'am, no addictions, ma'am. I mentioned initially.
Okay,
Yes, ma'am. Ma'am, the other summary is that of a 14-year-old girl with normal birth and development history, with an incomplete vaccination history, presented with a subacute history of 4 months of progressive decline in scholastic performance, with apathy, irritability, with generalized myoclonus, leading to falls with rigidity without any motor, sensory, bowel, bladder, or cerebellar features. Uh,
cognitive decline we have to assess whether it's just a apathy, irritability, or it's any other thing as well. And decline in scholastic performance was due to apathy, or whether she was having other domains involved.
yes,
So that we have to take the detailed history. Anything else to add, sir?
Nothing actually. I feel the poor scholastic performance should be changed rather than because
Yeah.
she's 14-year-old. You can keep scholastic maybe for 6 year or 7-year-old child. You can tell pure scholastic, but at 14 years they'll have much more cognitive functions. They'll be doing more activities. So actually, you can there will be something else in the history. I think you have missed it. because there'll be something else in the history, what happened in the home or outside or some functions. So it's predominantly cognitive dysfunction. I think there is a better term
Yes, sir.
because you put the scholastic because you know the case is SSP and the staging of SSP stage one is scholastic. That may be the reason you put it that. That happens when you
Then,
know the diagnosis and come back to the history.
yes,
Always in exam, take the case openly, as if even if you know the diagnosis, take it openly as if you are going to evaluate it. Otherwise, you will be get stuck into it, and examiner will know that you know the diagnosis.
yes. So
And this can be
coming,
written as a 4 month progressive history of a cognitive decline in the form of what cognitive domains you are getting, okay, along with a generalized myoclonus, which initially to be whether it was generalized or associated with multifocal myoclonus or not, okay, leading to
yes,
falls. And along with that, there is rigidity or spasticity we don't know yet, okay.
yes,
And
It's a stiffness.
if
Only you will keep over here as a stiffness. You can't differentiate. You have to examine your patient to differentiate among these two because you don't have any other associated features along with without any motor sensory or bladder power or cerebellar features. So then you will go on to symptom analysis.
And if you want to include the scholastic, you can even put, if you want to include scholastic so that you want to go towards SSP, you have to act more brilliantly and intelligently and put it like which started with scholastic performance followed by cognitive dysfunction like this and this is this. Then that includes both.
yes, sir.
Okay, please go ahead with symptom analysis.
Yeah.
So the symptom analysis that initially she was having difficulty in studies in reading and writing, so that would localize to the association cortex for the
Actually, we don't
language.
know what happened in scholastic properly. It can be an attention because she developed lately developed apathy. Not lately, soon after she developed apathy. So it might be predominantly attention because it is more of frontal. I mean, because there was no apraxia as per the history, there was no involuntary movements. Um, she was not having any language disorder. So I think it is more of attention might be or frontal dysfunction might be the reason.
Yes, sir.
Subcortical frontal more likely from your available history. Or else the history has to be more detailed. That is why, see, when the history is having less details, you'll have this issue at the when you're localizing. If history has details, the 50% of the issues will be solved out.
Yes,
What do you feel, ma'am, about reading,
Yeah,
writing?
actually, that is why I mean we cannot tell at this point of time whether it's an inferior parietal lobule or it's a frontal lobe or it's a connection between occipitoparietal lobule. It is not clear over this point, so I don't think we can localize with this. The detailed part
in
is needed to differentiate whether
And
whether it's an inattention or it's a language dysfunction or it's actually a parietal lobe dysfunction. The three things are different.
and again, the irritability, there was not much history about irritability in the history you presented. There is nothing much
Adolescent
in the
kids are
history.
anyway irritable.
Yeah, so you cannot, I don't think you can put irritability as a localization thing. Attention and empathy, we can agree.
yes, sir.
Episodes of decreased attention, I don't think she had. She had continuous, no? She has difficult to remember things. That is something just progressive. If you are having something episodic in between normal, then it is something episodic even. Either a metabolic thing happening like a mitochondrial disease going to having in between metabolic or some other metabolic like hyperglycemia or some other metabolic or it is a seizure or recurrent strokes. So what she was having is a consistent, continuously progressive thing for last 4 months. So you cannot keep episodic decrease in attention also.
Only decreased attention and then localize it too.
Yeah, decreased attention was there, apathy was there, and we don't know whether what happened to the studies exactly. It looks like more of a either a global dysfunction or a frontal dominant.
Yes,
And actually, with this history, we also cannot localize whether it's a cortical dysfunction or subcortical
Yeah,
because there is no
from the
apraxia.
history, I felt more of
Essence.
subcortical than cortical. The initial history.
Yeah, because
But it,
it's not a language is not there, apraxia is not
yeah,
there, agnosias are not there. Okay, and along with that, you are getting a subcortical nerve image of like history also. So it seems to be more of a subcortical thing than the cortical one. So the details, further details are needed to differentiate it.
and
Okay,
even the rigidity, we are not sure that it is rigidity or spasticity because the history is not
yeah,
complete. So that
yeah,
also
that is
that,
there. Yeah.
that is why the history has to be very detailed. Otherwise, you will land up in trouble when you are going to explain the localization. If the history, the patient and bystander is not telling a proper history, then you keep it open, like keep all the possibilities, and keep only those things you are sure about.
Yes.
Mm.
You
Again,
can
in
keep if you're not
myoclonic
sure,
joint. Yes,
you can
sir.
keep
Please
increase in the
continue.
tone, probable rigidity bar, spacity. I'm not sure because in the history I'm not able to get it. That you can
Yes.
keep. Otherwise, if you're specific on the history, you can keep it as rigidity. Otherwise, keep it as increased tone.
Yes.
And again, for a myoclonic joint with fall, it can be subcortical, it can be cortical. You have told regarding sensitivity. Okay, and the progression of a myoclonic joint. Whether started from the trunk and then moved to any other body part, or it started from the limb and then to became the spread over the whole homunculus. So currently you cannot say directly whether it's a subcortical or cortical one. The stimulus sensitivity is very important when you differentiate these two, or whether any associated lapse of consciousness was there or not. So
Yes.
that
Yeah,
has to be
stimulus.
come in history, and if you tell those things in history, then you can localize. Okay, I'm dealing with a subcortical now. That is subcortical where you are saying.
Ma'am, subcortical, like in case of an SSP, it is because of the thalamocortical circuits, the
That is because
myoclonus.
you know the
The
diagnosis, but here you are
yes.
not doing the diagnosis. You're starting with
Yes.
the
Yeah.
history. So keep it open. That is why that the problem happened when you have the diagnosis. You're trying to read the theory and coming back and putting it in your examination won't match. You have to
Yes.
explain whatever you have, whatever case you have. You explain that. Diagnosis may be anything. It may be something else. It may be SSP. You can even argue at present it is not SSP. I will tell you that I am telling you that this is not SSP. I'm arguing that this is autoimmune encephalitis. Can you disagree? If I am the examiner, I'm going to tell that why do you thought of SSP? I'm telling it is autoimmune encephalitis. Can you tell me some points against autoimmune encephalitis? It's not there. You're not sure.
Mm.
You're not investigated. You are not gone to examination. So don't put your theory into your practical exam. Practical exam, be it very straightforward. Whatever you get from the history, try to analyze that and try to talk on that. Otherwise, you will end up in trouble.
Okay. Yes.
Rigidity and spasticity, madam has told already. Like if there is clonus is there or toe walking is there, those favors more of spasticity.
Yes, sir.
Stimulus sensitive is cortical, and also the face involvement. The if it's rhythmic or arrhythmic, multifocal, all those things will tell you.
Yes, sir. Focal mobility. Yes.
Yeah.
So the differentials, I had kept mainly three differentials.
When you keep the differentials, no, you can if you are not able to get anything, you can remember the code which when long back Chandra madam used to tell vitamins. You can tell vascular infections, tumor trauma, A for autoimmune. Like that, you can keep all the possibilities. Even thyroid also is possible because all myoclonus, cognitive dysfunction, endocrine, all those things will come. So you have to like you remember that code and at least put something in the if like inflammation you keep something, autoimmune you keep something, endocrine metabolic you keep something, nutrition you keep something. You will get lot of DDs because always think of treatable DDs first.
Okay. Yes.
And why
Actually,
cyanosis first? Why not NCL? I mean, PME cyanosis is very rare. The Lafora, the NCL, they are more common.
Yes, sir.
So what is difference between myoclonus of Lafora versus NCL versus cyanosis? Is there any difference?
In the myoclonus,
What is the pattern of myoclonus among these three PMEs?
It's a cortical myoclonus.
No. Among these three, is there any difference in pattern of myoclonus?
Sorry.
In Lafora, it's more of a fragmentary erratic myoclonus. It's a multifocal kind of thing. Okay. Versus in NCL, it's mostly a truncal or the generalized one. The ceredosis is again a generalized one myoclonus. And in NCL, the visual component is late. It's not from the onset that you will get a visual deterioration. And the patient is having so much cognitive. Yeah, and so patient is having so much cognitive decline. She is bedbound because of that falls. Might be there's still and we the detailed cognitive function. She might be more cognitive dysfunction. She's not telling the definite because she's not. Yeah, and my voice is not clear. Hi, Dr. Pranav, my voice is clear or not?
Ma'am, it's clear now.
Okay. So, in case of your this what I was telling, yeah, in NCL, the visual deterioration is not from the starting. It's after from the onset of disease. It's just a 4 months from the onset of disease.
Yes, ma'am.
So it will come later. So ceredosis is a very rare condition. So first to keep the common thing, and then again the treatable thing will come first. So you can even divide your differentials in examination. I mean, when you are giving an exam, you can say that as it is a 4 month history, so I'm keeping my treatable differentials first, and in my treatable differentials again the infection. Why not infection? Because there is no chronic fever, weight loss is not there. So that's why I'm keeping infection. The second thing, I'm keeping autoimmune first. What kind of autoimmune? The primary autoimmune encephalitis and the secondary autoimmune diseases. Like lupus, you can keep. Okay, then you can keep regarding this Hashimoto's encephalitis. They are also having cognitive decline, significant myoclonus these patients are encountering. Then parathyroid abnormalities, deposition disorders. So those things you can keep in first thing, and then you will see that among the degenerative or the infection with the degenerative thing, we can keep the HIV. Then we
रात
can keep
मम्मू भी खा
MSG.
लेती है मिला देना
Yeah,
एक मम्मू खा
I
लेना
think someone's
Somebody's,
mic is on. Yeah, somebody's mic is on.
yeah, basically, when you see such a case, no, the first thing you should take is the before you going into diagnosis of something non-treatable, first you take this is very something which happened very fast. In 4 months, she went to bedridden. Do you think like we have progressive myoclonic epilepsies and all, like 3 or 4 months, they will go this much bedridden and all? Less likely.
Less likely, sir.
So, yeah, so you always keep treatable things first. Because it is a subacute onset, it's not a chronic thing. It's very like 3 4 months is very fast progression for this
Yes, sir.
age. And
Yes,
again
sir.
for Sarat, like that, I don't know whether it is a separate entity or like we have only text. I mean, we have only have some antibodies we know to test right now. So many of these Hashimoto's encephalopathies may not be Hashimoto's encephalopathy because they might be having some other antibody which we don't know how to test. That is why their presentations are so weird. I had seen 1 2 or 3 cases which are very weird presentation. Everything is negative except the TPO is so high. But ultimately, they all responded to rituximab.
Yes, sir.
So we don't know whether it is a separate entity or whether it is a something which we don't know. So we can keep all those things. Now, these are treatable because she's very subacute onset and very fast progression.
Yes, sir.
Of course, this also comes as DDs, but lower down the list.
Yes, sir. Treatable to be kept first.
SSP is fine. SSP can have progression slightly faster than PME, but PME usually progress very slowly, not this fast.
Yes, sir.
And what autoimmune encephalitis? You just can't leave it
You,
open.
you can
Autoimmune
keep even
encephalitis.
you can keep even mitochondrial. You can keep even Wilson's or other storage disorders because as per the history, she had some rigidity, some extrapyramidal plus movement disorder plus cognition.
Sir, I had initially kept an extensive history, but then because they were mostly not fitting and were all rare possibilities, so then I just kept predominantly first three differentials.
No, but these are not the first things you kept. If you want to remove, you could have removed PME also.
Yes, sir.
Ultimately, when you're evaluating, investigating, this might be SSB. But from the history, you can keep a lot of things. Even after examination, many of things may be removed.
Yes.
Please
Anything to
go
add,
ahead
ma'am?
with examination. Yeah, no, sir. Please go ahead with examination. Yeah, doctor, please go ahead with
Yes,
examination.
yes, ma'am. So in the clinical examination, first in the vitals, her pulse was 80 per minute, blood pressure 94 by 60 millimeters of mercury, with a respiratory rate of 14 per minute. And in the RS examination, the air entry was equal bilaterally. In the cardiovascular examination, S1S2 was present and no organomegaly was there. Uh, in her head to toe, no pallor, icterus, clubbing, cyanosis, lymphadenopathy was there. No neurocutaneous markers and no or dysmorphic facies were seen. Then in higher mental function, she was awake, was irritable, was oriented to person, uh, right-handed, and her attention was impaired as her forward digit span at the time of examination was 1, and a backward digit span she could not do. Serial subtractions she could not do. Then in her language, in her spontaneous speech, she had to be coaxed multiple times to speak and spoke in single words. In her comprehension, she was pointing to command to a single object. And yes, no, when I asked her if her father is at with her at present, so she answered in yes. And in her complex comprehension, also she can follow only single step commands after multiple attempts of coaxing. Because her attention and her language was impaired, so I was not able to do the other uh, testing of the higher mental functions in the patient. And then I moved on to the cranial nerve examinations. The pupils were normal size and reactive. The fundus, she was not cooperative. In her extraocular movements were full and free, with no flattening of nasolabial folds. Her gag was equal and normal active.
ഞാൻ കഴിച്ചുകൊണ്ടിരുന്നെന്നാണ്
In her clinical examination, the bulk was symmetrical. The tone was increased in her upper and lower limbs with rigidity, and there was axial rigidity as well. The power, the formal testing could not be done. But there was no overt weakness or paucity of movement of any limb or side. She was able to stand and walk with support of all four limbs, and was able to move all four limbs against gravity. Her deep tendon reflexes were hyperactive and the plantars were flexor. In her sensory examination, she was withdrawing limbs to deep stimuli, and the testing of vibration and joint position I was not able to do due to the poor understanding of the patient. In her cerebral examination, there was no gaze of nystagmus. There was no intentional tremor when she was reaching for objects. There was no titubation. There was no pendular knee jerk. There was no wide base gaze when she was standing with support. Yet when I made her to stand, she was able to stand and was walking with the support with a normal stance and swing face, with episodes of sudden jerk of head going backwards with the opening of mouth, and she would fall if she was not held by her father, and they occurred at around every 10 seconds without any stimulus sensitivity, and no meningeal signs were present.
Extrapyramidal examination.
Ma'am, there was no bradykinesia which was and there was the blink rate was normal. There was rigidity which was present at axial as well as appendicular, but for the bradykinesia, she was not able to follow the command. And pull test I did not do.
And what regarding her myoclonus? How did you describe it?
Ma'am, she had a generalized myoclonus with a sudden jerk, with her head going backwards with opening of mouth without any stimulus sensitivity which was there, neither to a tactile, neither to voice, neither to light.
And was there any change in frequency of myoclonic jerks? Was it only in the standing or walking, or was it there when she was in lying down or sitting as well?
Ma'am, they were present when she was lying down, when she was sitting as well, but they were seen more prominently when she was standing because of the fall. But they were present when she was sitting as well.
Was it only in trunk or other part of body were also involved?
It was generalized, the whole body was involved.
There was no fragmentary or other limb movement or separated that fragmentary myoculus was not there.
No, ma'am.
Only the jaw opening was there.
Yes, ma'am. मतलब, her head would go backwards and her jaw would open. That was seen, and then and she would fall.
Go back to your starting of examination. Okay. So there was no organomegaly in your patient.
Yes, ma'am. No organomegaly, ma'am. Not or not.
And no
Not.
dysmorphic facial. Okay. And in
Yes.
higher mental functions, how did you check for handedness in this patient? The patient
Ma'am.
was not that cooperative at that time.
Yes, ma'am. Yes, ma'am. The handedness, ma'am. I asked her to hold a glass of, matlab what? I gave her a glass, and then she used her right hand to hold it. Then I also asked of, and then I also then asked the father that previously which hand she used to do, and then because of that I said that she is right-handed.
I mean, if your patient is this much disoriented, it's better not to tell right-handedness over here. I mean,
Okay, ma'am.
sir, what should be done? I mean, in the patient when she is disoriented, sir. Sir, yeah, Dr. Vaishak, sir. Okay. So ideally, if a patient is disoriented, it's better not to comment on handedness because
Okay.
it needs testing, and the
Yes,
testings
yes,
need a conscious cooperativeness.
yes.
Okay. So I mean, on history basis, you can tell, but on examination, either you can test it, or if you can't test it, it's better not to comment.
Okay, ma'am.
Okay. And
Yes, ma'am.
attention, if a person is irritable or your patient is disoriented, definitely the attention is going to be impaired.
Yes, ma'am.
Okay. Okay. Go to next slide. So how do you test for yes or no command?
Ma'am, we asked them ki whether is it raining at the present. So she'll say that whether it is yes or no, or whether at present, matlab it should not include any other domain, like it should not include orientation to the place.
I
So
mean,
we'll
asking
ask.
if father is present with her or not, it's very coarse that we asked. So it should give some refineness. I mean, you can ask whether your father's name is this or not. Getting
Okay,
my point. So some comprehension should go there. I mean, whether a father is with there, few things work at subcortical level.
okay,
So if you want to actually check the cortical functions, you have to give them just some thought process. The
okay,
pointing object is fine, just ask them to point where is fan, where is chair. But when you're asking for yes or no, you are actually going from a very simple comprehension to the mildly complex one.
okay.
Okay. And then you ask
Yes.
for the complex comprehension. Could she do the complex comprehension?
No, ma'am. She was not able to. She was only able to follow single step commands. Other than that, she was not able to do.
She was not able to. Okay, then go ahead. Other domains.
She was not cooperative and not able to do, and the attention was very poor, so I was not able to
So
perform
that
the other tests. Yes, ma'am.
okay. And then Panda's vision. Could you test her vision?
No, ma'am, I could not test her vision, ma'am.
Some finger counting or from some distance. I mean, was she cooperative enough for that? No.
Ma'am, no, ma'am, finger counting at distance I did not do, ma'am. Ma'am,
Okay.
I tried initially for, matlab to tell her what she was able to see in the room and things like that if she was to, but she was not able to respond to that.
So was she aphasic or was she disoriented?
Ma'am, any single domain per se was not involved, that it was only because of an aphasia which was going there was an attention issue as well. Then there was a language impairment as well, as she was not speaking in complete sentences of it. and along with that, attention was also involved. So multiple domains were involved.
When you were just asking her repeatedly, but was she making full sentences, or it was just she was just giving reply only in one or two words?
I'm only in one or two words.
Okay. And along with that, your patient was disoriented also.
Yes, ma'am. Was oriented only to the person. Yes.
Okay. 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 Go ahead. So, what extra did you get in your examination?
Ma'am, in examination, ma'am, there was a presence of rigidity which was there, and uh, the reflexes were brisk. The formal testing of the power and of the sensory was not well, could not be done. And then
Tone
I
was
made her
normal.
walk. Yes, ma'am.
Tone was at least spasticity was not there, right?
Yes, ma'am.
She
There
was
was rigidity present.
there was hyperreflexia, but
Yes,
the
ma'am.
tone was not in the favor of pyramidal involvement. Right.
Yes, ma'am.
Okay.
Then I made her walk, ma'am, and then to see the presence of fall during her gait, which then I recorded, ma'am.
Okay. Just show it, please.
Yes, ma'am. This one cannot be. Ma'am, is the video? Ma'am, is the video see, ma'am?
Yeah. Please play it.
Yes. Yes,
Yeah.
ma'am.
It's very broken. Video is very broken. It's not fluent.
Should I play it again?
Yeah, please play it again. It was very broken.
Ma'am, it was not playing through the PowerPoint, so I have opened it directly.
Hmm. It's very jerky actually. The video. Okay, leave it. So from examination, what extra did you get?
Can you mention the gate that
Mm. So the gate is that she was walking with support, and there was a normal stance and swing phase with a normal step width, and the feet were not turned outside, and there was no there was no uh, uh, there was no wide base gait, or the patient was not swaying to any side. She did not require multiple steps while turning. And in between the gate, she was having episodes. In like in this video, she had two episodes where she had her head went backwards, and she would have fallen if was not held by her father. Hello. Hello.
Sir, you are not audible. Sir?
And Dr. Vaishak has left, I think.
Okay. Sir is not there, sir? Dr. Vaishak sir has left?
Yeah, he left. You can continue.
Okay. Okay. So, Dr. Pranay,
Yes.
can you just do the again localization and what things did you add in your history?
Yes, ma'am.
So now, what your examination ruled out? What are the differentials that you kept now your examination ruled out, or what did it rule in? What extra did you
Ma'am,
get?
there was a presence of a negative micronus on in the examination, along with the presence of a severe cognitive involvement in a significant global cognitive involvement which was present, and along with that there were no extra extra neurological manifestations such as a presence of dysmorphic faces or a presence of optic atrophy which could have been seen, or a presence of any organomegaly, or which would have
So optic
pointed
atrophy
to a
cannot comment. No, you could not see your fundus. You could not
yes
see
ma'am.
your fundus. So still you cannot comment on optic atrophy or other fundus examination.
Yes ma'am. Yes ma'am.
So what did you actually add? You just got that not the family was saying that is just a the patient is having only some cognitive domains are affected, but in actually in examination you get a gross cognitive decline.
Yes ma'am.
The patient is just oriented to the person only. She is not oriented to time, not oriented to the place even.
Yes ma'am.
So it might be that the patient is delirious.
Okay ma'am.
Getting my point?
Acute
Might
on a
be that
chronic event.
yes. So it is there that if she might has got delirium superimposed on her underlying illness. So how will you differentiate a delirium versus actually this cognitive decline or we say dementia?
Ma'am, a delirium, there will be a there will be the maximum involved is attention in a delirium, a delirious patient, but there will be fluctuations that the patient will be able
Yes.
to answer sometimes, and the same questions might not be able to answer at a different point of time.
Yes, exactly. So that thing, whenever you are examining and you are getting an inattentiveness, you have to ask this thing to family. So does
Yes,
she
ma'am.
answer these questions at home, or is there any diurnal variations to these answers or inner cognitive status?
Yes, ma'am.
Okay, so that is important. And again, after that, you got some language dysfunction, but you cannot say in scenario of delirium.
Okay. Yes, ma'am.
The person might not be willing to give answer, or she is not inattentive to you. So in that situation, you cannot see. It can be an hypoactive delirium.
Yes, ma'am.
Okay. So one thing
Yes,
you
ma'am.
got. Other than that, in the cranial nerve function, we just could not examine her fundus, so we cannot comment on her visual functions or what was her fundus because lot of things depend on that. But
Yes, ma'am.
one thing you can check for KF ring. So
Yes,
that
ma'am.
has to
Okay.
be checked in this patient. In
Yes,
general
ma'am.
examination, you will comment regarding thyroid enlargement. Any lymph node is there or not? LR is there or not? Why? Because we kept possibility of lymphomas.
Yes, ma'am. Thyroid pathology. Yes, ma'am.
Yes, and again then that you will check for some needle injection sites that whether is any marker of substance abuse is there or not. So you will just check all those things. If you get it,
Oh,
then you will tell it. Okay.
okay.
Yeah. So and then you got some you confirm your extrapyramidal thing, but there is only rigidity, no
Yes, ma'am.
tremor, no
No, ma'am.
bradykinesia. It was
No, ma'am.
not having any extrapyramidal involvement. It's just a false she was encountering because of generalized myoclonus.
Yes, ma'am.
Okay. So now, what do you think? What differentials now you can comment on, or do you want to rule out?
Ma'am, so this rules out a probable, well, not exactly rule out, but makes it less likely to have the patient having a progressive myoclonic epilepsy, and the phrase. Yes, ma'am.
Why do you think that this is not a progressive myoclonic epilepsy?
Ma'am, lower down because there is not presence of any dysmorphic facies. For example, if we would have thought, although it's very rare in sialidosis, then with the then with Lafora bodies also there has to be there was no history of any occipital seizures as well, and any fragmented myoclonus was not there.
Hmm.
And
So
the negative, yes, ma'am.
all the differentials you previously kept, you still cannot rule it out.
Yes, ma'am, cannot rule it out.
So nothing we could rule out. We just could get that their patient is delirious superimposed on an underlying illness. So it's an acute something is went on the chronic thing.
Yes, ma'am.
Okay. So how would you approach now? Again, you will keep the treatable thing first. So what investigations you will do?
Ma'am, as the patient is having delirium on top of a chronic event, so first I will look for any medical causes of a delirium. Most commonly, electrolyte abnormalities can cause delirium in such patients. So I'll check the electrolyte abnormalities. I'll check the counts of the patient if the patient is having leukocytosis, and then the metabolic markers, the SGOT, SGPT, and the renal markers of the patient. If they are normal, and then afterwards I'll then go for the uh, thyroid function test, the HIV or serum, a VDRL, and the HIV, HbCG, and HCV. If and then alongside I'll plan a patient for an EEG.
Yes, EEG is very important in these patients. And the first
Yes,
thing we don't know our patient is delirious or not. We have to ask when you're examining and you are getting such kind of patient, you have to ask them whether it's actually a delirium or they are inattentive. Getting my point. So
Yes,
we are currently from your examination, I'm not sure whether it's delirium or your patient is having frontal dysfunction and inattentive.
yes, ma'am.
Okay, so you will check for all the causes of delirium. Along with that, you will go for an EEG. So what do you expect in EEG?
Ma'am, if in a case of subacute, if you are suspecting the patient to have SSP, then the EEG will show us initially the background will be normal, but with the progression of the disease, there will be slowing of the background, and along with that, there will be presence of slow wave discharges, which are a very high amplitude and pseudo periodic with long interval in between
What
them.
is pseudo periodic?
Pseudo-periodic means that in the majority of the EEG, there is a difference between the discharges
What
of
is ILA classification of periodicity in EEG?
ma'am, according to
How does
ILE,
ILA glossary give term?
ma'am, they say a periodic and quasi-periodic.
Yeah, so it's a truly periodic or it's a quasi-periodic or it's a non-periodic. Pseudo-periodic is not a term.
Yes,
You know? So what is true periodicity?
ma'am, when the interburst interval or the difference is less than 25% throughout the record for the majority of the record, and when the interburst interval is between 25 to 50%, then the difference in the interburst interval is 25 to 50% for the majority of the record, then
How
it is
much
quasi,
majority?
when for more than 50% of the record.
More than 80%.
More than 80. Okay.
Okay.
Yes.
So the true periodic is it's at less than 25% interperiodic interval should be there, and the quasi is from the 25 to 50. If it's above 50, it's what?
It's
It's
non-periodic.
non-periodic. There is nothing like pseudo-periodic. Okay.
Yes, ma'am.
And what is the difference between the periodic discharges of SSP versus CJD?
When the interburst interval, it's a short periodic versus a long periodic discharges. The short
What
periodic
is
in
the short
CJD,
periodic? What is
ma'am, less than
what
4
is
seconds.
yes, less than 4 seconds is short periodic, and the more than 4 seconds is long periodic.
Yes,
Okay. And what other than that?
ma'am, the other causes of periodic discharges. Hello, ma'am. Hello.
What are the other differences? What is the difference in their morphology? What happens with sleep? What happens with awakening?
Yes, so when the discharges of SSP persist during sleep, and the important way which where we can increase the specificity is that they will increase on giving yeah, a sedation with the diazepam or lorazepam, the discharges of SSP.
And what happens with myoclonus?
When the myoclonus of SSP, ma'am,
The discharges of SSP or the burst of SSP is time locked to the myoclonus.
yes, ma'am, yes, ma'am.
And that is a very important thing. So that's why whenever you are doing an EEG of a person with myoclonus, you should be there. Or a technician should be that much just concerned regarding that, that your the discharges should be time locked at that time, or whether they are different. Okay.
Yes, ma'am.
And what is there in the cases of PME? What happens?
Ma'am, in PME, initially there will be any in PME is also initially the background will be normal, but as the disease progresses, there is a progressive slowing of the background, and then there can then along with the progressive slowing, there can be presence of spike and polyspike and wave discharges. But alongside, an important thing is the presence of photosensitivity in PMEs, which occurs at low frequencies of 1 to 8 hertz.
What is the difference of PME, the photosensitivity of NCL versus LAFORA, and versus your sialidosis or your Unverric Lundbach?
And that time, and that I I'll
So that actually you read. So in case of, it's a low frequency sensitivity, but in case of Unverric Lundbach, they are usually not photosensitive. Versus a LAFORA, it's around 1 to 8 hertz, but it's more towards a 6 to 8 hertz. When versus an NCL, they are more of a 2 to 3 hertz.
okay.
So whenever you are encountering a young child with this photosensitivity that is coming at 2 to 3 hertz, so then you will again reevaluate for NCL.
Okay.
What is the most common this photic frequency on which your photosensitivity comes on? Among other, including other epilepsies as well.
Ma'am, in the, I mean, 12 to 18 hertz frequency,
It's 15 to 20 hertz
15
mostly.
to 20 hertz.
Okay.
Yes.
Okay. And what happens in autoimmune encephalitis in EEG?
I mean, autoimmune encephalitis, again, there can be a slowing which can be seen. There can, because of encephalopathy, but especially if in the patients of an MDR, there can be a presence of an extreme delta brush.
So what is an delta brush? What is extreme
Ma'am,
delta?
ma'am, there will be delta waves which are seen in the frontal leads, and along with that, there will be superimposed small low voltage discharges which will be seen, which looks like a brush.
And on which limb? Ascending limb, descending limb?
Uh,
I mean, in sleep also, when your person is in the drowsy or in the transient state, transition to sleep, there is a frontal predominant beta, and along with that, a delta is also there.
okay,
That happens, no? If you see your patient in Egypt, they're going transiting into your sleep from the alpha, your alpha drops out, and you start getting frontal beta. Along with that, you start getting delta waves. Not exactly the delta, you start getting theta waves.
yes, ma'am. Around
Okay,
4
so
hertz.
what happens in these patients of this thing? In case of your extreme delta brush, there is this beta is over where the ascending limb of delta.
Acha, okay, ma'am.
That is important to differentiate. Okay.
Yes, ma'am.
Okay. What other else investigation will you do other than EEG?
And then we'll do an imaging for the patient.
Yes, the imaging is important because you have kept other differentials as well.
Yes, ma'am.
Okay.
Yes, ma'am.
So what do you expect in different diseases?
Uh, For example, ma'am, in SSP, the most predominant pattern is that of white matter hyperintensities, which is predominantly seen in the posterior part, and then with time they progress to anteriorly. So initially they'll be seen in the parieto-occipital area, but can be seen in the frontal uh, subcortex as well. And in an initial stage, it can be there can be an accompanying edema as well if the disease is active.
Okay. And
Then, ma'am, ma'am, in autoimmune encephalitis, in NMDAR, in LGI, in Casper, there will be predominantly limbic encephalitis in 80% of NMDAR, in 30 to 40% of Casper and LGI. But if it's a GABA form of an autoimmune encephalitis, GABA A, it has a very specific multifocal involvement which is seen on an imaging. While GABA B again will show us a limbic encephalitis pattern, which is a bilateral medial temporal will be hyperintense.
okay. And what do you expect in cases of other PMEs?
I mean, in PME, man, there can be white matter hyperintensities that are seen.
The non-specific white matter hyperintensity. In case of Lafora, you will see predominantly over the occipital area,
Yes,
the cortical subcortical hyperintensities. Okay.
yes.
So, okay. Anything else to discuss, sir, or we can conclude today's session? Or anything else anyone want to ask?
Yeah, if anybody have any question, you can take. Otherwise, we can conclude.
Okay. So, Dr. Pranay, it was a very good session. Uh, this is for all the students. Whenever you are presenting a case, just keep things open. Okay. Don't just stick to the diagnosis that we are expecting. Just go on to the detailed history of each and every component. If they're giving a poor scholastic performance, then you will ask what actually they are having interference with, and then what are their activities of daily living, and then you try to localize the thing. Okay. And after that, in the examination also, you will see what extra things you added onto your history, and then you will localize. And always keep a treatable differentials first, then to go on to the degenerative. Okay.
Yes, ma'am. Thank you so much, ma'am.
So yeah, thank you everyone. Thank you for today's session, sir.
Yeah,
Thank you.
yeah, we can conclude the session. Thank you, Dr. Soumya and Dr. Baisha, for moderating this session, and thank you, Dr. Pranay. We'll continue tomorrow. Thank you, everyone.
Yeah,
Thank you, sir.
thank you, sir. Thank you.